Welcome back, everyone, to another deep dive. Today, we're going to get those stethoscopes out, make sure our boots are tied tight, and get ready for a deep dive into chest injuries, especially for all you EMTs out there.
Love it. And perfect timing, too. I was just reviewing our emergency care and transportation of the sick and injured book and slides, along with this chest injuries PDF. Talk about a crash course, right?
Oh man, tell me about it. And seriously, these injuries, they're not messing around. Chest trauma is one of the biggest reasons people end up in the ER, so knowing our stuff is crucial.
You said it. We got to be ready for anything, those lights and sirens, the whole 9 yards, and manage these situations like the pros we are.
Absolutely. Now, before we get ahead of ourselves, though, I was hoping we could do a quick review. Our sources mention these terms, ventilation, oxygenation, and respiration, and I'll admit sometimes I get those three a little mixed up.
Oh, I totally get it. They're definitely easy to confuse. But think about it this way. Ventilation is all about getting air in and out, like with a BVM.
Okay, yeah, that makes sense.
Right. So then you've got oxygenation, which is all about getting that oxygen into the bloodstream. Like picture hooking someone up to some high flow O2. That's oxygenation in action.
Gotcha. So what about respiration? Where does that fit in?
Respiration is like the grand finale. It's where the magic happens. Think deep down in those tiny air sacs where the oxygen actually meets the blood and does its thing.
Okay, now it all clicks. So if a chest injury throws a wrench in the system, it's going to mess with all three of those things, right?
Exactly. Imagine a pneumothorax, a collapsed lung. You've
Yeah.
got air leaking into the pleural space, which is that area between the lung and the chest wall.
Right, like a deflated balloon.
Yeah, exactly. So the lung can't fully expand, meaning less air is getting in, and that messes with the whole chain reaction of ventilation, oxygenation, and respiration.
Makes total sense. Speaking of understanding how things work, I love how our source talks about chest anatomy. They compare a chest x-ray to looking under the hood of a car. Kind of makes those anatomy lessons more exciting, don't you think?
It's such a great way to think about it. And just like a mechanic, we need to know our parts. So let's pop the hood, right? We've got the ribs forming that protective cage and the sternum holding it all together in the front.
Right, and then the diaphragm, which is doing all the heavy lifting when we breathe.
You got it.
And we can't forget about the lungs themselves.
Definitely not. They're kind of the stars of the show in all of this.
For sure.
And nestled right between those lungs is the heart, hanging out in the mediastinum, which is like the chest's central station. It houses the heart and all those major blood vessels, the great vessels coming to and from the heart. And then we've got the pleura, that slippery membrane lining the chest cavity and lungs. It's got a little bit of fluid for smooth movement.
Okay, so picture this. You get to a fender bender, right?
hmm
And the driver's holding their clavicle clearly in pain. Looks like a fractured clavicle. But here's the thing. What else should our EMT brains be thinking about?
Oh, good catch. Because remember, the clavicle is right up there by the rib cage, so a fracture there. That's a big clue to look out for potential rib fractures underneath. And remember, you've got those important blood vessels running under each rib.
Oh,
A fracture there could mean internal bleeding, even if you don't see it right away.
yikes. Talk about a hidden danger. Okay, so we've got our anatomy down, but how does breathing actually work?
Well, it all starts with that diaphragm we were talking about. When you
Right.
inhale, it contracts, pulling downward, and at the same time, those intercostal muscles between your ribs contract too, lifting the rib cage up and out. So it's real teamwork here. This increases the space inside your chest, so air gets sucked into those lungs.
And then when you exhale, everything relaxes and the air gets pushed back out.
Exactly.
So simple but important.
Right. Now, here's something you probably remember from your EMT training: spinal cord injuries. Let's say you've got a patient with an injury below the C5 vertebra. You might think they can't breathe, but that's not always true.
Really? Why is that?
It's all thanks to the phrenic nerve, which is like the control center for the diaphragm. This nerve, it actually originates from higher up in the neck at the C3, C4, and C5 level. So even with a spinal injury below C5, the phrenic nerve might still be working just fine.
Wow, that's wild.
Right.
So they can still breathe, even with a lower spinal injury.
Exactly. The diaphragm can still do its job. It really makes you realize how interconnected everything is in the human body.
And how crucial those details are when we're assessing patients.
Oh, for sure.
Okay, so anatomy and breathing check. But let's get to those chest injuries. Our sources divide them into two main types, open and closed.
And those are pretty self-explanatory when you think about it. A closed chest injury means there's no break in the skin. Think like a punch to the chest.
Okay.
But an open chest injury, you're talking about something like a gunshot wound or stabbing where there's an actual breach in the chest wall.
Right, you can practically see the danger with an open injury. But with a closed injury, I feel like it'd be easy to miss something serious going on internally.
That's the thing. You could have a bruised heart, called a cardiac contusion, or even bruised lungs, a pulmonary contusion.
Wow.
And you might not even see any external signs, but they can be really dangerous.
Yeah, messing with the heart's ability to pump and the lungs' ability to exchange gas. That's why we're always taught to be super suspicious with blunt force trauma to the chest, even if we can't see anything right away.
Absolutely. And when it comes to open chest injuries, what's the golden rule for EMTs?
Oh, you know it. Never remove an impaled object.
Never, ever.
It's tempting, but you got to resist that urge.
Exactly. It might be acting like a plug to stop bleeding, so yanking it out could cause more problems.
Totally. Like a whole lot of bleeding we're not equipped to handle out in the field. Plus, moving it could do even more damage.
Right. It's best to stabilize it and let the surgeons deal with it at the hospital.
Absolutely.
Now, let's talk about blunt force trauma for a second. Those impacts from car crashes, falls, assaults.
Where the body's basically a pinball.
Exactly. Especially in those high-speed crashes, think about what happens to the heart and aorta. The body keeps moving, even when the car stops. That sudden deceleration,
Right.
it can be brutal on the aorta, that main artery from the heart. It's like whipping a garden hose. It can actually tear or rupture, which is called aortic shearing.
Isn't that one of the leading causes of immediate death in those types of accidents?
It is. Almost a third of people who die from car accidents, it's from that kind of injury. So that seatbelt sign, it might mean a lot more than just some bruising.
Wow, that's scary.
It is. So
Yeah.
always be suspicious, especially with those high-impact collisions.
It's a good reminder that buckling up is serious business. Okay, so we're at a scene, maybe even a crash like you described, and we're dealing with a potential chest injury. What are some of those red flags, those telltale signs that we need to be looking for? It's not always going to be a gaping chest wound, right?
Oh, absolutely not. Sometimes those signs can be subtle, but our job is to pick up on them. Pain is a huge one. If someone's clutching their chest or they wince every time they breathe,
Huh.
that's a big red flag. And that pain, it can lead to those rapid, shallow breaths we're trained to look for.
Makes sense, because those deep breaths would probably hurt even more. And bruising. I've seen some nasty bruises on the chest after an impact.
No.
Really drives home the force involved.
It does. And don't forget to actually feel the chest wall with your hands. Check for any crepitus,
Right.
that crunching sensation.
Yeah.
That basically screams fractured ribs.
Okay, so we've got pain, weird breathing, maybe some bruising, crepitus. What about difficulty breathing? Isn't that pretty common with a lot of these chest injuries?
It's a hallmark sign for sure. But here's the thing. Shortness of breath or dyspnea, it can be caused by a ton of things. Remember that patient who was convinced they were having a heart attack?
Oh, yeah.
Turned out to be a panic attack.
Yeah, I've been there.
Right.
You can't jump to conclusions, especially with something as general as shortness of breath.
Yeah.
Got to look at the whole picture. Right.
Absolutely. Mechanism of injury, other symptoms, their medical history, the whole 9 yards. We're like detectives piecing together clues.
I like that analogy. Okay, so let's put ourselves in the EMT's shoes for a second.
Yeah.
Say we get a call, motor vehicle accident, single vehicle into a tree. We arrive at the scene, and there's a 30-year-old male driver. Conscious, but not having a good day. Chest pain, difficulty breathing, those classic signs. What are our first moves?
Okay, game on. First things first, scene safety. We got to make sure it's safe for us, our partners, and of course the patient. No down power lines, leaking fluids.
Right. Got to protect ourselves first.
Exactly. We can't help anyone if we become casualties ourselves.
Couldn't agree more.
And while you're checking the scene, take a look at the vehicle. Is it stable? Any chance it could move and trap someone?
Oh, good point. You're right. Got to be aware of those hazards. Okay, so the scene's secure, vehicle stable. It's time to approach the patient. What's our initial interaction like?
We're approaching with caution, keeping in mind that spinal injuries are definitely possible with that kind of impact. We introduce ourselves, get his name, and assess his level of consciousness. Is he alert and talking, or is he only responding to pain?
Right. Our AVPU alert, verbal, pain, unresponsive.
Exactly.
Basic, but so important.
Crucial. And while you're doing that initial assessment, we're scanning for any obvious bleeding.
Right. You got to stop the bleed.
That's always a priority.
If we see major bleeding, it's direct pressure, bulky dressing, the whole 9 yards. But let's say for now there's no major external bleeding. We move on to the ABC's airway, breathing, and circulation. Where do we start with the airway?
We start by seeing if he can talk. Can he tell you his name, what hurts? That's a good sign the airway is open. Of course, we're also listening for any sounds of obstruction like gurgling or stridor, anything that sounds like he's struggling to breathe.
Right. Those are the sounds you don't want to hear. And we can't forget about potential spinal injuries, especially with a head-on collision like this.
You got it. You'll want to maintain manual stabilization of his head and neck during your assessment.
Okay.
Don't let those C-spines slip your mind.
Never. Okay, so let's say the airway seems okay for now. What about breathing? What are we seeing and hearing?
We're looking at everything. The rate, rhythm, and quality of his breathing. Is he gasping for air? Are his breaths shallow and fast? Is there symmetry in his chest movement?
Right.
Is one side moving differently than the other? And of course, we're listening to those breath sounds.
Or lack thereof.
Exactly. We want to hear those good, clear breaths on both sides. Decrease or absent breath sounds, especially on one side. That could be our first clue that something like a pneumothorax or hemothorax is going on.
Okay, so eyes on the chest, ears with the stethoscope. What about circulation? What are we looking for there?
We're checking that pulse. How fast is it? Strong? Regular?
Right.
And don't forget about the skin. Is it pale? Cool and clammy?
Oh, yeah, good point.
Those are signs the body might be in shock, maybe from internal bleeding.
Even if we don't see any external bleeding, we can't rule it out.
Absolutely not. We've got to keep that internal bleeding alarm bell ringing in our heads, even if we don't see it with our own eyes.
Exactly.
Especially with that kind of impact.
Okay, so we've done a quick assessment of his ABCs. And based on what we're seeing, the chest pain, the difficulty breathing, the mechanism of injury, it seems pretty clear that this is a load and go situation, right?
Absolutely. We got to get him to the hospital and fast, but that doesn't mean we just throw him in the ambulance and hit the gas. We've got to provide supportive care during transport, too.
Right. Make him as comfortable as possible. What kind of supportive care are we thinking?
High-flow oxygen through a non-rebreather mask is a must. We want to pump those lungs full of the good stuff.
For sure. Got to get that oxygen flowing. And depending on how much he's struggling to breathe, we might need to step in with positive pressure ventilation, using a BVM.
Exactly.
Give those lungs a helping hand.
Right. It's like giving his lungs a little boost.
Okay, so oxygen's going. Maybe we're assisting his breathing. What else is crucial during transport?
We've got to be vigilant. Chest injuries can throw us curveballs. We can't get complacent just because he's in the ambulance. We're constantly reassessing, keeping an eye on those vital signs, his level of consciousness, how he's breathing. We need to be ready to adjust our game plan if things change.
It's like they say, expect the unexpected. Okay, so we're on our way to the hospital, lights flashing, sirens blaring, and we notice his breathing is getting worse, even with the oxygen. His O2 sats are dropping, and you can see his neck veins starting to bulge. What's going through your mind at that moment?
Those signs are practically shouting, tension pneumothorax. It's a life-threatening condition, and we got to act fast.
Okay, this is where our training really kicks in. We need to relieve that pressure, right? What do we do?
We need to perform a needle thoracostomy, also known as a needle decompression.
Right, needle decompression.
It's a procedure where we insert a needle into the chest cavity to release the trapped air.
Okay, time for some serious intervention. And throughout this process, we're in constant communication with medical control, right?
Absolutely. We're a team, even if we're miles apart. We need their guidance and authorization for procedures like this.
Of course, teamwork makes the dream work.
Ah.
Okay, so we've got our patient, we're monitoring closely, and we're ready to act if things go south. It sounds like managing chest injuries is a delicate balance between observation, quick thinking, and decisive action.
You got it. We're constantly evaluating, reassessing, and adapting our approach based on the patient's condition. And speaking of adapting, remember those sources we talked about? They go into a lot of specifics about these injuries, way more than we can cover here. But they do highlight a few things about those deadly dozen that are worth mentioning.
Okay, let's unpack some of those specifics. We've talked about ventilation, oxygenation, respiration, but our sources also mentioned tidal volume. What's that all about?
So tidal volume is basically the amount of air that moves in and out of the lungs with each breath.
Okay.
Think of it like the ocean tides, but with air instead of water.
Okay, I like that. So why is tidal volume important for us EMTs, especially when we're using a BVM?
Because we want to make sure we're delivering enough air to be effective.
Right.
But we also don't want to overdo it. Overinflating the lungs can cause more problems.
Makes sense. It's like blowing up a balloon too much.
Exactly. You want to find that sweet spot.
Right.
Now, our sources also mention something called minute ventilation. This is a big one. It tells us the total volume of air moving in and out over a whole minute.
Okay.
We calculate it by multiplying the tidal volume by the respiratory rate.
So if we've got a patient with a tidal volume of 500 milliliters and they're taking 12 breaths per minute, their minute ventilation would be 6 liters per minute, right?
Exactly. You got it.
Yeah.
And understanding these numbers can help us make sure we're ventilating our patients effectively.
It's all about finding that balance,
Hmm.
providing enough support, but not going overboard.
Exactly.
Okay, so we've covered some key terminology. Now back to those deadly dozen injuries. One that we haven't really talked about yet is a diaphragmatic tear. What's the deal with those?
Okay, so imagine your diaphragm like a strong curtain that separates the chest cavity from the abdominal cavity, right?
Okay, yeah.
A diaphragmatic tear or a rupture is basically a hole in that curtain.
So things can start moving around where they shouldn't be.
Exactly. A tear can let abdominal organs sneak up into the chest,
Oh no,
where they can cause serious problems for the lungs and heart.
not good. What are some signs that we might be dealing with a diaphragmatic tear?
It can be tough because the signs might be really subtle, especially if it's a small tear. You might hear bowel sounds in the chest, which is definitely a red flag.
Right, that's not where they're supposed to be.
Exactly. The patient might also complain of abdominal pain or have difficulty breathing. You might even notice decreased breath sounds on the affected side.
Okay, so if we even suspect a diaphragmatic tear, it's safe to say this is a load and go situation, right?
Absolutely. This is not something we can fix in the back of the ambulance. They need surgery, and the sooner the better.
Okay, makes sense. So next on our list of deadly dozen injuries is an esophageal injury. And this one, it's not pretty.
Not at all. The esophagus, it's basically the highway for food, going from the mouth down to the stomach. And guess what? It runs right through the chest cavity.
Oh, right through the danger zone.
Exactly, making it vulnerable to all kinds of trauma.
So we could be talking about something as straightforward as a stab wound or something less obvious like that blunt force trauma from a car accident.
Exactly. A forceful enough impact can rupture the esophagus.
And that can't be good.
No, it can have some really serious consequences.
What are some of the red flags that would make us think esophageal injury?
Well, you might see blood in their vomit, which is never a good sign. They might complain of chest pain or have trouble swallowing. And keep an eye out for subcutaneous emphysema, that's air leaking into the tissues of the neck and chest.
It feels like bubble wrap under the skin, right?
Check.
Okay, those are definitely signs we don't want to miss. So let's say we suspect an esophageal injury. What's our game plan?
Just like with a diaphragmatic tear, our main focus is on supporting their vital functions and getting them to the hospital as fast as we can. That means airway management, supplemental oxygen if they need it, and being prepared to manage shock if it develops.
Right, because an untreated esophageal injury can quickly become life-threatening. Okay, another one down from our deadly dozen list. Let's talk about massive hemothorax.
We talked about hemothorax before. That's blood accumulating in the pleural space, right?
Right.
But a massive hemothorax, that's when things get serious.
Okay, so what makes it massive?
We're talking about a significant blood loss, usually more than 1,500 milliliters into the chest cavity.
Wow, that's a lot of blood.
It is, and it can lead to hypovolemic shock really quickly.
Would the signs and symptoms be similar to a regular hemothorax, just more intense?
Exactly. You're looking for those classic signs of shock, pale, cool, clammy skin, rapid and weak pulse, low blood pressure. But with a massive hemothorax, those signs are going to be much more obvious.
Okay, so in both cases, our treatment is the same. Support those vitals and get them to definitive care, ASAP.
You got it. Time is of the essence when we're dealing with massive bleeding.
Speaking of time-sensitive situations, let's talk about thoracic aortic dissection. This one always makes me think about ticking time bombs.
That's a great comparison. A thoracic aortic dissection is a tear in the inner layer of the aorta, that big highway for blood flowing from the heart.
Right.
Now, when that tear happens, blood can start to flow between the layers of the aorta, and that creates something called a false lumen.
A false lumen. So it's like a detour on the highway, but for blood.
Exactly, and that detour is not a good thing.
I bet it's not.
That false lumen can weaken the aortic wall and put it at risk of rupturing, and a ruptured aorta, that's a really bad day.
Often fatal. Right.
It can be, even with quick medical attention.
Okay, so definitely not something we want to mess with. What should we be looking for if we suspect a thoracic aortic dissection?
Well, it can be tricky because the signs and symptoms can vary. But a lot of times, patients will describe a sudden tearing chest pain, like someone's ripping them open from the inside.
Oh, wow. I can't imagine.
It's excruciating, and the pain often radiates to the back.
Okay.
You might also notice a difference in blood pressure between their arms, or a weak pulse, or even no pulse in one or both legs.
Okay, so sudden, severe chest pain that radiates to the back, blood pressure differences, weak pulses, those are serious red flags,
Yeah.
especially after a high-impact injury.
Exactly.
We're thinking aortic dissection and getting them to the hospital
You
immediately.
got it. And during transport, we're doing everything we can to keep them calm.
Right, no need to add any more stress to the situation.
Exactly.
Okay, we're nearing the end of our deadly dozen list. We've got 2 more to go, myocardial contusion and pulmonary contusion.
Right. We touched on these earlier. Myocardial contusion, that's a bruise to the heart muscle.
Right, and pulmonary contusion is a bruise to the lung tissue.
Exactly. Both often caused by blunt force trauma to the chest.
Those high-impact car accidents, falls, that kind of thing.
Exactly. That force of impact can really do some damage.
So with both myocardial and pulmonary contusions, it seems like our main focus in the field is supportive care, airway management, oxygen, and rapid transport.
You got it. Stabilize and transport. We're getting them to the experts who can provide that higher level of care.
Makes sense. Okay, so we've made it through the deadly dozen chest injuries. That's a lot to remember.
It is, but think of it as adding more tools to your EMT tool belt.
I like that.
Every call, every patient, it's an opportunity to learn and grow.
Speaking of learning and growing, our sources also talk about specific pre-hospital interventions for chest injuries. One that they emphasize is positive pressure ventilation.
Right. We talked about that a bit earlier. Positive pressure ventilation, that's when we're using a BVM to help the patient breathe. It's a really important tool for anyone struggling to get enough air, like those with flail chest, pneumothorax, or even pulmonary contusion.
And it's all about balance, right?
Yes.
We want to provide enough support, but not overdo it.
Exactly. Find that sweet spot.
Speaking of balance,
Yeah.
our sources also really stress the importance of occlusive dressings for open chest wounds.
Oh, absolutely.
Yeah.
Occlusive dressings are crucial for sealing up those wounds and keeping air from getting into the chest cavity. Ideally, we want to use those commercial dressings with the built-in flutter valve.
Right, those are great.
But as we've all experienced in the field, sometimes you got to improvise.
Oh, for sure.
You use what you've got.
Plastic wrap, foil,
Exactly. Whatever it takes to create that seal.
whatever it takes. Now, what about pain management? Chest injuries are incredibly painful, and that pain can make it even harder to breathe.
That's a great point. Our sources don't go into tons of detail about pain management for EMTs, but it's something to consider.
Right, because we don't want to add to their suffering. Definitely something to discuss with medical control based on your local protocols.
Exactly. Always follow your local protocols.
Okay, so we've covered a ton of ground here. Anatomy, breathing, the deadly dozen chest injuries, some important terminology, even specific interventions.
It's been a journey, a deep dive into the chest.
It really has. But I feel like we're missing one important piece. You, our listener, out there in the field, facing these situations every day. So let's turn the tables for a second. Imagine you're on scene. You've got a patient who's been in a pretty bad car accident. They're conscious, but their breathing is getting more and more labored. Their skin is cool and clammy, and you can see those neck veins bulging. What's your first thought?
Those signs point to a tension pneumothorax. We've got to act fast.
Exactly.
Yeah.
So you contact medical control and ask for permission to do a needle decompression. But here's the thing. Medical control is hesitant. They're worried about potential complications. How do you advocate for your patient in that moment? How do you explain why this procedure is so important right now?
That's such a good question. It really highlights something so important about our jobs. Clear communication and patient advocacy.
It's not enough to just know the steps. We have to understand the why.
Yes. We need to be able to explain our concerns clearly and with confidence, explain that a tension pneumothorax is a time-sensitive emergency. If we wait, it could be really bad.
We have to be their voice when they need it most.
Exactly. Exactly. It's in those moments that we really show why we do what we do.
Absolutely. And, you know, it's not just about knowing the procedures and treatments. It's about understanding why we do them, right? That's how we build confidence in ourselves and with medical control.
I totally agree.
Okay, so as we wrap up this deep dive into chest injuries, what are some of those key takeaways you want our listeners to remember?
Well, first and foremost, never underestimate the seriousness of a chest injury. These are common calls for us. but they can go downhill fast.
Right, those internal injuries can be tricky. We have to stay vigilant, especially with those closed injuries.
Exactly. And remember those deadly dozen we talked about.
Oh, yeah, those are crucial.
Know them, learn their signs and symptoms, and be ready to act quickly.
Like having a mental checklist.
Yes, exactly. And never forget those basic principles. Scene safety always comes first. Always.
So important. Protect yourself, protect your partner, and then you can protect your patient.
Exactly. And in terms of treatment, remember that supportive care is key. Airway management, oxygen, controlling any bleeding, and getting them to definitive care as quickly and safely as possible.
Right, we're stabilizing them so they can get to the experts at the hospital.
Exactly.
Perfect.
And finally, never stop learning. EMS is always changing.
Oh, for
New
sure.
research, new techniques, new equipment.
Keep things exciting.
It does. It makes it exciting, challenging, and so important.
I totally agree. Well, that about wraps up our deep dive on chest injuries. Just a reminder, this episode was made for you. You are incredible listeners out there on the front lines of emergency medical care.
You are literally the first line of defense for people in need.
It's true.
And your skills and knowledge make a difference every single day.
Couldn't do it without you.
We hope you learned something new today, or maybe this sparked a new thought, or maybe it just reminded you of something you already knew.
Either way, we hope this episode gave you a little more confidence out there on those tough calls.
That's what we're here for.
Absolutely. So keep asking those questions, keep learning, and keep making us proud.
We're all in this together.
We are. Until next time, stay safe and stay curious.